Good afternoon, and thank you for joining today's webinar. I'm Ann Cook, and I'm very happy to welcome you to the program. We call it Real Patients, Real Stories, and what we're trying to do is just give you a closer look at what happens on the ground, if you will, in patient care in an accountable care model. What happens that's different, what happens in a focus on quality, and what happens to patients and family members when they receive care in an accountable care model like Kelsey-Seybold Clinic. Our presenter today is Dr. T.J. Patel. Dr. Patel is the Chief of Hematology and Oncology for Kelsey-Seybold. He is also the Medical Chief of the Kelsey-Seybold Cancer Center. He's been with Kelsey-Seybold since 2005. He is board certified in internal medicine with a sub-certification and specialization in oncology. And as you may already know, our cancer center at Kelsey-Seybold has the distinction of being named the nation's first freestanding cancer treatment program by the prestigious American College of Surgeons. If you have questions during the presentation, please go ahead and type those questions in. You'll see an area on the right-hand side of your screen. So we'll receive those questions, and Dr. Patel will answer your questions at the conclusion of his presentation. So again, thank you for joining us, and we're going to turn the microphone over to Dr. Patel.
Thank you, Ann, for giving me this opportunity to speak about our cancer center. I'd like to start out by telling you all about cancer center quality. This is a big area of focus over the last couple of years in cancer care. In fact, the American Society of Clinical Oncology, which is our national organization, has a big push in demonstrating and proving quality. In fact, it has different measures that cancer centers are expected to adhere to prove to the patients and to payers that quality is being delivered. And some of the ways we have demonstrated that is by applying for and receiving accreditation by various agencies, as outlined here in the slide. For example, one of the largest agencies that does accreditation is the American College of Surgeons. And we here at Kelsey were actually the first freestanding cancer program in the country to get that. And what that means is the following. Most cancer programs are associated with a hospital. They're not freestanding like Kelsey. Now, we were the first one because at Kelsey we have everything under one umbrella. We have surgeons, we have radiology, we have oncologists, we have social workers, and all the supportive care that is needed in cancer all folded under one umbrella. So we were able to apply for the certification and receive it. Subsequently, it is my understanding that another cancer program in the country, sort of like Kelsey, freestanding, has received accreditation, but the vast majority are all hospital-based. So I think that's quite something special that we were able to achieve. A couple of other certifications. We've been recognized by the breast centers for excellence. That's important for our breast cancer patients, our patients who get mammograms and imaging and biopsy. This is another marker of excellence when it comes to breast cancer, which, as you know, is one of the most common cancers out in the country. The third certification also applies to that, which is radiology certification. Radiology is a big tool that is used in cancer, not only for diagnosis but also for following patients. What we deliver here at Kelsey-Seybold Cancer Center is not only good care but also cost-effective care, and I'm going to talk a little bit about that. One of the important areas to understand about cancer care is what sort of guidelines and treatment are we following. NCCN is a consortium of cancer centers that was put together many years ago to allow oncologists in practicing areas to follow the latest and greatest guidelines, and that's what we follow here at Kelsey-Seybold. So those guidelines are called the NCCN, and it's an alliance of 23 of the world's leading cancer centers with examples like Memorial Sloan Kettering, UCLA, MD Anderson, etc. And these guidelines are updated almost quarterly, and they're readily accessible. They're free via internet and email. And as long as you follow the guidelines, you are covering the vast majority of cancer, something like 95%. And as long as you follow what's in those guidelines, you're delivering the latest and greatest based on medical evidence. So following those guidelines is a very important thing. In fact, probably on a daily basis, I personally will open these up in front of the patient via computer probably 3 to 5 times a day and show them that this is your cancer, these are the guidelines, and this is exactly what we're doing. And it's meaningful for the patient. They can see that we're doing what is considered to be the latest and best. The way we deliver cost-effective care is by reducing needless duplication, fragmentation, and poor communication, and not doing repeat testing. And a lot of that is truly given by electronic medical record. It allows for looking and seeing what happened before, what's planned for the future, and it allows us to communicate with the primary care physician and to avoid duplicate tests. In fact, I'll give you a quick case. About a week ago, I was in Spring, and we had a new patient who had a new diagnosis of a rare abdominal type of cancer, and I ordered a CT scan on him, and he was a PPO patient. The CT scan was done, and then subsequently the insurance company contacted me to do a peer-to-peer to get approval for the CT scan. It turned out that the insurance company had noticed that the patient had a CT 2 months ago at an outside facility, which was not in our computer system. The patient did not mention that. None of us knew about it because I wasn't done at Kelsey, so it wasn't in our EMR. That's just one example of how, if everything was done under one system, we could have avoided a duplicate test, for example. So that specific example was very telling in that having an outside system just doesn't allow for coordinated care. So it's good to have all this under one computer. Here at Kelsey, you're assigned your own physician, nurse, pharmacy team. One of the things that's important in community is that you're not a number. They actually know you by name and as an individual face. When patients call us, we actually know who they are just when they speak and they give us their name. It is rare when we need to actually pull them up by their number or by their date of birth. That's the personal touch of a community cancer center like ours. We also have electronic medical record data where labs, test result, pathology, etc. can be relayed to the patient in a quick, real-time manner. So patients oftentimes can plot out their own results and bring them with themselves at the appointment so they can better understand what's going on. One of the areas we're very proud of is our Cancer Center Nurse Navigator and Breast Center nurses. What they do is they fast-track many of the areas of concern. For example, in cancer, one of the goals we have is to contact the patient within 24 hours of having a referral placed. And that's what the Nurse Navigator's job is. They will actually contact the patient as soon as the referral is placed, giving them that comfort and that personal touch that we're here for you, we're here to take care of you and bring you into our system and get you directed in the right manner. The same is done in the breast center. Anytime a patient has an abnormal mammogram, the nurses take over, they make contact with the patients, they kind of guide them through it and they ease them through the system because that's a time of high anxiety, as everyone can understand. Sorry about that. Okay. Next slide here. This is a summary tool of our cancer team. It starts out right in the middle top by the initial physician, which is usually the primary care physician or specialist. They will oftentimes get some clue that something may be abnormal either by exam or by a lab test or by some kind of radiology study. They will then put in the referral to our cancer center, and you can see all of us 5 doctors there on the top right-hand side. Our nurse navigator, Terry, she will get the referral on the computer, and like I said, our goal is 24 hours to contact the patient. She will actually call them, make initial contact, and then guide them into our system. Once they see the doctor, a treatment plan is put together, and that is delivered by the rest of the team as shown in the wheel. For example, our nurses, our infusion team, our pharmacist, our social worker, Joan, she's shown there. She's great at helping the patient deal with issues such as financial issues, insurance issues, transportation, or just simply counseling and social support and guiding them in the direction that they need for that. We also do a lot of financial counseling. Cancer care is quite expensive, as you know. So oftentimes there are resources out there that patients do not know about, and Deanna and her team there, as pictured, will help guide the patient on all those resources. We also have our own lab, which is important because it makes things a little faster for our cancer patients and more personal and just a little more convenient for them. They're coming up here quite often and getting labs on sometimes once a week basis, so it just makes it nice for them. And then, of course, we have management structure to oversee all this. Some specifics about each of our special areas of care. On top is Terry, who is our nurse navigator. She's been with us for quite a few years. She's actually a very experienced chemotherapy nurse. She because of her experience, is aware of what sort of treatments are done for many of the common cancers. So when she gets the referral, she anticipates and knows what the questions will be that the patient will ask, and she will actually explain things to the patient and get them into our system. That helps the patient understand what they're going to get, who they're going to meet, why, etc., and it helps relieve their anxiety. So that's a huge thing that we have, and many cancer centers do have a nurse navigator. That ties back into that American College of Surgeons accreditation. One of their criteria was that you have a nurse navigator to help guide the patients in. Deanna, who's in the middle, is our financial counselor. She's the head of that team. She also helps meet with patients and help them understand what will occur during their treatment. It also helps them understand what is covered by insurance and for patients' obligations, and to help them seamlessly get through their treatment without too much undue extra stress that they don't need at a time like this. On the bottom is Shane. Shane is our head of pharmacy. Chemotherapy is mixed on-site. It is a very specialized process, very sterilized, very regulated by the Texas State Board of Pharmacy. And we actually have dedicated cancer and chemotherapy pharmacists and nurses who deliver and mix the drugs based on the doctor's orders. So it's quite important that we have this service, and actually the equipment there is just quite phenomenal. If any of you guys ever want to come see it, we'll be more than happy to show it to you. I'm going to go into an accountable care case study and show you how we take care of a patient here at Kelsey, and compare that to what would happen in a non-accountable care model to illustrate the differences between not only efficiency of care but also how cost is at least improved or minimized in our setting. So this is an actual patient of mine. He's 55 years old. He unfortunately has metastatic colon cancer that has spread to the liver. And I'm going to show how we took care of him in our accountable care model versus what could have happened to him in an outside non-accountable care model. So one day recently, this was about maybe 3 months ago, he came here to the main campus because he had a fever and dehydration. He's been our patient for quite some time now, so he understands our system. He's been well educated on when to call, when to come in, and he understands when we're available and what sort of services we can provide. So he actually just walked up, told my nurse that I'm having a fever and that I just don't feel well. They contacted me. We put him back into the infusion area and started hydration and did blood work to try and sort out what's going on. If he was not in an accountable care model, he probably would have been told to go to the emergency room, wait for whatever time period that is required, and then be seen there, generating significant additional cost. Subsequently, in our model, what we did, based on the blood test that we got that same day, we realized he had bile obstruction, which was causing his fever and his symptoms. I picked up the phone, spoke to one of our radiologists, spoke to the GI doctors, i.e. the liver specialists, and decided that the best approach would be to drain the bile via a procedure that would be done at the hospital. Since he was stable, we actually gave him antibiotics, fluids, and sent him home and said that you can come back to the hospital tomorrow to get the procedure done. You can imagine if he was in an outside system, the ER doctors not having access to our records, not having access to his history, or at least not even having the time to fully go into it, would probably repeat multiple tests, including scans, labs, etc., to try and figure out what's going on, and of course generating cost and time. Subsequently, the next day in our system, the patient came to the hospital, went to radiology, had the testing done, had the procedure done, or at least planned for it. Turned out he needed an even more extensive procedure, which was scheduled the next day at Friday. Again, he was stable, so we said go ahead and go on home and come back Friday to St. Luke's. If it was in the traditional care model, ER doctor would again see all the abnormalities, correctly consult GI doctor who would come down and see the patient, contributing to additional consultation costs. Subsequently, on Friday, the patient came back to St. Luke's, went to radiology, had the procedure done. We were informed on Friday that he would have to be hospitalized 23 hours. We immediately picked up the phone, called our hospitalists, had them make arrangements to admit the patient and take care of him for 23 hours. On Saturday, he was discharged home, and we had already given him an appointment to see me the following Tuesday. In a traditional care model, he would have likely been admitted, had surgery in the next day or two, hospitalized for those couple of days, and then been discharged afterwards. So in summary, total hospital time was basically 23 hours in our system with a lot of outpatient care, outpatient stabilization, which leads to patient convenience and comfort and to lower cost, as everybody knows, compared to a minimum of 3 days in the hospital, which obviously everyone understands the costs involved there, plus inconvenience on the patient's end. So to summarize, what are some of the outcomes here? First of all, we're able to avoid the ER. Everyone knows what sort of inconvenience and time and expense there is involved there. The reason he was able to avoid the ER is because he was well educated by our team and our staff and knew what capabilities we had and when to come in and when to call. Every new patient that comes through us and goes for chemotherapy, either intravenous chemotherapy or even oral chemotherapy, get a full counseling and teaching session by our chemotherapy nurses and pharmacists. So oftentimes they'll know what to expect as far as side effects, and they'll know when to contact us, either via phone or email, etc. Coordination of care here at Kelsey is quite important in saving costs and simply just getting better care. When he came in, based on his blood work, I had a sense of what was going on, so I was able to pick up the phone, call our liver doctors, call our radiologists, and they were able to look at the scans on the computer and tell us that what he needed was basically a bile drain. He didn't need to go to the ER, go to the hospital, get admitted. He needed this outpatient procedure, and we were able to do all that via simply the phone. So no extra cost there, no extra consultation. That's just part of us taking care of the patient on a day-to-day basis. Patient avoided delays in care. He was simply stabilized here at his convenience. He's aware of the staff here. He's familiar with all the team. He's got familiar faces here. Vilma, our nurse, he's very close to Vilma. He always asked for Vilma, was there the day he came in. She took care of him. He felt very comfortable with that. He took care of all the instructions I gave him, and he subsequently came back to St. Luke's the next day. Obviously, the net effect is that we avoided a lengthy hospital admission. He would have been in the hospital maybe 3 days with extra costs, extra work. That's lost time for the economy. That's lost productivity. This patient still works, actually. He works at a law firm, and any time that he's away is lost productivity for the law firm and lost income for him. So that's to summarize. That's our accountable care model here in action at Kelsey-Seybold with a real cancer care patient. At this point, I'm going to have Ann see if we have any questions. I'll be more than happy to answer them for you.
Thank you, Dr. Patel. I think we have a few questions. And so Val is going to bring those up on the screen for us, and we'll begin asking Dr. Patel to give us his thoughts on your questions. So we'll go to the top of the list, and the first question is, at what age should a person have their first colonoscopy?
So typically, most patients who do not have any specific conditions, such as a family history of colon cancer or some inflammatory bowel disease, the most normal risk patients, the age is at 50. If they do have a strong family history, or if they have a specific genetic mutation that predisposes them to colon cancer, and by the way, we do some of that genetic testing, then it often starts much earlier, sometimes at 40, sometimes even at 25, depending on what specific issue goes on. But the simple answer, assuming normal risk, is the age of 50.
And then there's a follow-up question about colorectal cancer, and that is, how quickly does a polyp advance? What sort of time frame does that take place on typically?
Great question. It actually depends on what the polyp is. So let's assume it's a normal risk patient who has their first colonoscopy at the age of 50 and they have a polyp. When the polyp is removed, the pathologist looks at it, and then they will tell the GI doctor what sort of polyp it is, whether it's a benign polyp, early precancers, more advanced precancers, or frankly cancer. Obviously, if it's cancer, then they'll go to a surgeon and come to us eventually. But assuming it's a non-cancerous polyp, very detailed and very specific guidelines have been developed that will tell the GI doctor when the next colonoscopy is. So if it's fully benign, it could be 5 to 10 years. If it's somewhat premalignant, it could be 3 years. If it's a very highly premalignant, it could even be 1 year. So those are very well-established guidelines that the GI doctors use to determine when the next colonoscopy occurs.
We have some additional questions. A question, what type of cancers are treated at the Kelsey-Seybold Cancer Center, and are there types of cancer that Kelsey-Seybold does not treat?
Great question. So vast majority of cancers can be treated at Kelsey-Seybold Cancer Center. For example, all the common ones such as breast, colon, lung, prostate, melanoma, lymphoma. It's actually quite rare for any oncology program to have to send cases out to a specialized center. Usually that occurs when a cancer is rare or when there is no predetermined guidelines. For example, coming back to those NCCN guidelines, they cover about 95% of cancers. So if someone has one of the common cancers in that 95% and the guidelines exist on how to care for them and they're updated every quarter, then those patients can be treated at a cancer center like ours. Usually patients need to go to a highly specialized tertiary or even quaternary type cancer center such as MD Anderson or Memorial Sloan Kettering or UCLA, when they have something that is so rare that they are not in the guidelines, or when standard normal chemotherapy, surgery, radiation, etc. has not been effective and that no further options exist. Usually many times there are further options. Again, they're all in the guidelines and you follow them, but at some point when those options exhaust, then you have to turn to clinical trials, which are done at many different places.
Here's another question which asks, what is the difference between the Kelsey-Seybold Cancer Center and, say, other centers that are local in the Houston area, such as MD Anderson or the Stellan Foundation?
So what I tell patients is that if you have a common cancer that needs common treatment, we can take care of that just as well as any other cancer center. And in fact, even when you go to any other cancer center, you're going to get the same exact thing. It's all based on guidelines, it's all based on data, it's all based on scientific evidence. The difference with us is that it's a more coordinated system. Just like I gave this example of this patient where we had the computer system to guide us on his records, we had the other specialists, we had the scans. It just makes a nice seamless transition and coordination of care. And then the one biggest area I think that patients appreciate is the personal touch to it. Because we're not overly large, because we're not driven simply by numbers, we're driven by delivering good care. We know patients by name. It's much more personal here. When you call, we don't really even need to pull up your record, which, I mean, we do, but really we already know who you are just based on the name that you give us on the phone. So I think that's the main difference.
We'll take one more question, and this question asks, what is the environment like at the Kelsey-Seybold Infusion Center? What is it like for our patients when they come in?
So it's actually a very nice, personal, private area. When you walk in, there's individual bays that have lazy boys. They have chairs that patients and families can sit in. They have a TV. They have capability for internet, so that way patients and families can work. But they're all individualized with a curtain in the front so the nurse can come in and out. So it's actually a private, personal, yet functional space. It's basically a round or square structure with the bays on the outer edges, and the middle is where the nurses and the pharmacists are. So they can keep an eye as to what's going on, if the patient is having any issues or concerns, if they're having any side effects that need to be dealt with while the drugs are being delivered. And the pharmacists are right there. They're actually right up there, so that way they counsel the patients at their first visit. They mix the drugs. They help coordinate care with their nurses. They're reviewing the labs, etc. And then finally they get the final okay to mix them at our specialized sterile area, and then they're bought up and delivered. So it's actually a quite nice personal private space. And one of the neat things in closing that I'll quickly share is about 3 to 4 years ago, we have what we do once a year is called a Cancer Survivor Day, basically. And at one of those days, we actually asked a lot of our patients to actually submit artwork, and they actually put together either drawings or collages, and we actually put them up. So each of the bays, I believe we have close to 15, have patient-specific artwork. It's actually quite nice to look at. So I hope that helped. I hope that helps answer the question.
Yes, thank you so much, Dr. Patel, and thanks to all of our listeners and participants who joined us for the webinar today. We really appreciate you taking time from your schedules, which we know are very busy, to learn more about what we do here at Kelsey, what we're doing in the accountable care area. So we're, again, look forward to inviting you